Good afternoon, everyone. You are very welcome to today's webinar, Operationalisation of Integrated Care Chronic Disease Nursing Roles. The panel will be delighted to receive any questions you may have. Please use the Q&A feature located at the bottom of your PC or laptop screen. If you're using any other device today, you may find this feature located where the three dots are where it says more. Now, without further ado, I will hand you over to your host for today, Sandra McCarthy. Thank you.
Many thanks, Jean. Siobhan, I could just ask you to start sharing the slides there. That would be great. Colleagues, we're delighted to welcome you here today to our webinar on the operationalisation of integrated care nursing roles. My name is Sandra McCarthy. I'm a Director of Nursing and the National Nurse Lead for the Integrated Care Programme for Chronic Disease. Next slide, Siobhan. So what we hope to cover today during the webinar is an overview of our guidance document on operationalising integrated care nursing roles, which we launched during the summer last year. And my colleague Niamh Murtagh will go through that document with you. We have a panel discussion then where we'll be joined by 7 colleagues, advanced nurse practitioners and clinical nurse specialists across the specialities of cardiovascular, type 2 diabetes, COPD, and asthma. We will then hear from leaders in leading integrated care, Gemma Brennan, an operational lead in Dublin North East, Eileen Daly, who is an Assistant Director of Nursing in Connolly Hospital, and Claire Staunton, who is a former Assistant Director of Public Health Nursing. We hopefully then will get through some questions and answers, as Jean reminded you there with the function at the bottom of your screen for any questions you have for any members of our webinar today. And then I'm delighted I'll be joined by Dr. Sarah O'Brien, who's our National Clinical and Group Lead Advisor for the Integrated Care Programme for Chronic Disease. Next slide, please, Siobhan. So our integrated care programme for chronic disease, you'll see we have a lot of acronyms and abbreviations across these slides, but what it really is placing an emphasis on the prevention, early diagnosis and proactive management of chronic disease closer to home as possible. And I'm sure you're all familiar with this pyramid that has been developed and that is in a number of our documents. And we're working towards implementing this model of care. You'll see we've level 1 there, where we're hoping that people are living well with their chronic disease at home. And the examples of services then on the opposite side of the pyramid. General practice then, where we work with our GP practitioners via the chronic disease management programme. And then to the next level, which is our community and specialist ambulatory hubs, which we'll be focusing on today, and elements of the acute specialist ambulatory hubs, and then to specialised hospital inpatient care. So our chronic disease teams in the community are a critical component in supporting our shift left agenda, and it's offering supports to our GPs in caring for individuals living with more complex chronic disease and multiple long-term conditions through timely access to the MDT team, advice and intervention. Next slide, please. So what we have achieved today, and this data is from 2025, and if we look at it, we're delighted that we have 26 out of our 30 teams operational nationally. We have a phenomenal of over 100,000 total nursing contacts was achieved in 2025. And to put that into context, colleagues, that 100,000 contacts would have been within the 4 walls of the acute hospital prior to the implementation of the model. And we have had over 25,000 referrals to our nurses working in the hubs over 2025, which is a great achievement in terms of what we have done to date. Next slide, please, Siobhan. So colleagues, you may be aware there's currently some issues with the HSE website, and those documents that are referenced to the right, we had hoped to hyperlink them, but unfortunately not able at the moment. This Launch Your Care document, I'm sure you're all well aware of, and that's available on the Department of Health website. But those other 3 documents, along with our operationalisation of integrated care nursing roles, are available and accessible at the moment through hub on HSE land. So once you log into your HSE land account and access the ECC hub, you will be able to access those documents. But what we want to recognise is this shifting care left is a major culture change. And it's a culture change from ourselves as healthcare professionals working in specialised chronic disease conditions, but also for our patients who heretofore were familiar with the only way they could access specialist care was through the lengthy OPD waiting list or via ED departments. So now we have this opportunity where they can access specialist knowledge through our chronic disease community specialist teams. And that's aligned to the Sláinte Care's vision and providing right care in the right place at the right time. And the shift is already evident, as I demonstrated there in the previous slide, with the contacts and number of referrals which have occurred in 2025. But we're only starting, and we really do hope to improve on this year on year. And the entire chronic disease community specialist team are central to making integrated care real, embedding earlier intervention, reducing hospital admissions and ED attendances, supporting early discharge, and driving that cultural and operational changes required to deliver sustainable community-focused care. However, it'd be remiss of me not to recognise and acknowledge, the current difficulties that are experienced with implementing the care, and namely IT challenges. Some areas and some hubs have had different levels of progression with integrating with acute IT system and patient records, but we are all familiar with our national roadmap that's outlined in Digital for Care policy, which helps insist, where our end goal in terms of integration with technology. And there is significant work ongoing with colleagues throughout various different departments within the HSE. And also we're acknowledging that some teams aren't fully staffed at the moment, and there has been, some issues with implementing a fully staffed workforce, but we are working through that with colleagues throughout the regions. Okay, Siobhan, could I ask you just to stop sharing those slides there just for a moment? Thank you. Now it gives me great pleasure to introduce my colleague, Ms. Niamh Murtagh. Niamh is a change manager within the ECC programme and has been instrumental in developing these national guidelines for operationalising the integrated care chronic disease nursing roles. Niamh, I'll hand over to you now. Thank you.
Thank you, Sandra, for the introduction. I will provide an overview of the development of the operationalisation of the integrated care nursing rules guidance document and outline its main aims. The implementation of the chronic disease model of care in Ireland is a relatively new concept in the delivery of healthcare for chronic disease patients. Integrated care clinical nurse specialists, CNSs, and advanced nurse practitioners, ANP, posts were funded in the advent of the chronic disease model of care across the three specialities: cardiology, type 2 diabetes, and respiratory, specifically COPD and asthma. These posts support and empower people to live well with chronic disease in the community in a holistic and person-centred manner. A significant number of the integrated care CNSs and ANPs are now working in chronic disease services across the community specialist teams and in hospital settings. These services are developing at different stages in the health regions due to multifactorial reasons, and there are variances in local chronic disease services depending on local circumstances and patient population needs. Following our engagements and feedback received from relevant stakeholders, there was a recognised need within the Integrated Care Programme for Chronic Disease to provide further support, guidance and information to enable both professional and operational managers and nurses to navigate the implementation and evolution of the integrated care rules and to support linkages between the community and hospital settings. So examples were sought from CNSs, the 80-20 and 50-50 post holders, and ANP 50-50 post holders to draw on their lived experience on what makes these roles work in reality, and to understand the different ways and how people were implementing the services and identify factors that enabled them to do their job. So we looked at this information, collated and analysed it, and identified best practice aligned with the model of care. And in conjunction with these examples, we developed 18 key principles which underpin the guidance document. The document also outlines the role of the CNS and A&P based on the Integrated Care Programme for Chronic Disease national job descriptions, and includes the practical examples provided by the CNSs and A&Ps on how the roles work in reality. These examples illustrate the interventions and initiatives implemented and reflect the evolving nature of services and how nurses support the patient journey across full chronic disease end-to-end pathways. In the panel discussion, next you will hear directly from the integrated care nurses and APs working in chronic disease services and discuss how they've implemented and built local services, share practical advice and demonstrate how these roles are responsive and connected to patients' needs. Next slide, please, Siobhan. This slide outlines the key stakeholders for whom this guidance document was developed. Many of these stakeholders also contributed to the development of the document through a wide and extensive consultation and feedback process. During this process, a draft document was issued to over 120 stakeholders for input and feedback to ensure they could inform and support the final guidance, and also ensure the information within the guidance document reflected a national representation of the chronic disease integrated care nursing roles. Next slide, please, Siobhan. This slide represents the core themes underlying the 18 key principles outlined in the guidance document to support managers and nurses in implementing the integrated care nursing roles. A patient-centred service and a shared vision should be the key considerations underpinning all discussions and decision-making across key stakeholders in acute and community services in the delivery of integrated nursing services. Stakeholders should ensure opportunities are maintained for relevant CPD and provide access for experiential learning and opportunities to work with and learn from colleagues across both community and hospital sites. Key enablers to facilitate implementation of roles include national guidance documents, and I just mentioned one which was published as well in July 2025, which is the Roles and Responsibilities Matrix Guidance Document. This guidance document supports all staff working in integrated chronic disease roles to have a shared understanding of individual roles and responsibilities of the operational leads and the assistant directors of nursing, and ensure work practices are aligned with the model of care. And this document can be found on HSC Land in the ECC Hub under ICPCD resources. In their presentation later in the webinar, Claire, Eileen and Gemma will refer to these and other principles when they share the lived experience. They will give practical examples on how they effectively agreed an approach, identified partnerships and developed relationships between the community and hospital to facilitate the implementation of the nursing roles and the corresponding end-to-end care pathways for chronic disease patient care. Next slide, please, Siobhan. I just want to thank everyone on behalf of myself and Sandra who've contributed to the development of the document. I will now hand you back to Sandra for the panel discussion. Thank you.
Niamh, many thanks for giving us a real insight into the journey which led to the publication of the guidelines. And it's so obvious, and I know from working with you on it, that significant collaboration and stakeholder engagement occurred. And it's fantastic to have an end product now for everybody to refer to in terms of guidance and how to make this work, as you say, in reality. So thank you.
Thank you.
So colleagues, today's webinar is focusing on the emerging role of integrated care nurses in chronic disease, roles that didn't previously exist within the Irish healthcare system and now that are central to the transformation of care delivery across the HSE. These nurses, my colleagues on the panel today, are trailblazers. They're really operationalising the integrated care in real time, working across traditional organisational, professional and sectorial boundaries to deliver person-centred, coordinated care closer to home. Their roles represent a significant culture change, which I spoke about earlier, within the Irish healthcare system, shifting from a fragmented, episodic models of care to proactive, planned and integrated chronic disease management. This requires not only new ways of working, but new relationships, which our colleagues will speak further on later on in the webinar, but shared accountability and a strong focus on population health and outcomes. During this panel discussion, we'll explore how these roles have been operationalised, the challenges that colleagues have encountered, and the enablers then that help them overcome those challenges, and the real impact that integrated care nurses are having on our patients, on services, and the wider healthcare system. So first of all, I'm going to ask each of them to introduce themselves, where they're currently working, their role, and location. So I might start with you, Nicola, if you'd like to introduce yourself.
Hi, my name is Nicola Hyde. I am the acute 50/50 cardiovascular CNS for Portiuncula Hospital, affiliated with the East Galway Roscommon Hub.
And you're working in cardiology, isn't that it, Nicola?
Yeah, the cardiovascular CNS, yes.
Great. And Lorna, I'll come to you next.
Hi, my name is Lorna Nelany. I'm a respiratory A&P 50/50 in Sligo University Hospital and the Benbulben CDM Hub.
Great. And Anne, I might come to you next.
Hi, how are you? My name is Anne Fitzpatrick and I'm the Advanced Nurse Practitioner in Diabetes. I'm employed by Tala University Hospital in Dublin and I work with the Integrated Care Hub in that area, 50/50 role.
Thanks, Anne. Sinead.
Hi, my name is Sinead Duke. I work in the Galway Integrated Hub. I'm the 50/50 cardiovascular CNS and I work at Galway University Hospital in cardiology.
Thank you, Sinead. Mary?
Hi, my name is Mary Feely. I'm a clinical nurse specialist in diabetes and integrated care, and I'm working in the Midwest and I cover North Tip and East Limerick.
Great. And finally, Mairead.
Hi, I'm Mairead Lehan. I'm an advanced nurse practitioner in cardiology and I'm working in the North and South City hubs in Cork City and 50/50 with Cork University Hospital.
Great. Thanks, Mairead. Have I got everybody there? Haven't missed anybody?
I'm Alison, sorry.
Alison. Apologies, Alison.
No problem. Alison McAllister. I'm the respiratory CNS in the Dublin North Central Hub, aligned with the Mater Hospital, and I'm 80/20.
Great, Alison. Thanks so much. So colleagues, I'm going to start with the first question, and I suppose what I'd like to do is reflect on your journey within the integrated care program in chronic disease. And I'm presuming, but perhaps you can advise otherwise, that you all commenced within the acute setting and moved then to your integrated care roles. And reflecting on those previous roles working in chronic disease in the acute setting, how is that difference, or is there any key difference between that and your integrated care role now? And I might come to you, Lorna, first, please.
Yeah, I suppose one of the biggest things for me was setting up the clinics and working as an autonomous practitioner within a clinic. And really, I took a lot of time setting up that clinic and to see where my role as an A&P 50/50 hospital and community would work within clinics and the logistics of setting it up when you're trying to work between two sites. Yeah. So I did take time with that. And really it's set up as a one-stop shop. So we offer pulmonary function test, a full holistic assessment, diagnosis, education, and then follow up and referral on to other members within the team. So maybe physiotherapists or pulmonary rehab, smoking cessation. And looking at where you work with, along with the CNSs, but where that role is different and where you can complement each other as well at the same time. My clinics are generally in the morning time before the consultant clinic. So if I have any issues, then I can talk to the consultant in the afternoon, and it means that there isn't a delay if there's anything that I'm concerned about. I think really working across both areas brings the hospital and the community together, and I would hope that me working within the two areas and working with the people in both areas kind of brings everybody a little bit more together and kind of linking up with the teams and bridging the gap
between the two. Excellent, great. Thank you so much, Lorna, for sharing that. And not easy setting up, as I called you at the outset, definitely trailblazers. Nicola, I might come to you with the same question then. Any key difference between your previous acute role and your integrated care role now?
Yeah, I suppose the key differences I would see are predominantly for the patients. Instead of the patient, like one big thing I would notice is instead of the patient having to travel to you, the clinician can now travel closer to the patient's home. And this has such a huge impact, particularly for elderly patients traveling long distances. And we all know a lot of those patients are reliant on family members for transport. So in the hub that I'm in now, we have six different clinic locations for the patients. So that can reduce travel time by an hour or more in some instances. Which we all know is very different to the traditional hospital settings where, parking can be an issue and that sort of thing. So in my current 50/50 role, the other thing that I like about it is that I see the patient's whole journey from, admission to discharge and beyond. And by being able to work across both the hospital and community, we have the opportunity to support long-term management, not just one single point in time.
Yeah, no, they're really good points. Thanks so much, Nicola. And Anne, I might come to you. Your thoughts on your key differences between your previous role and this role.
Yeah, well, I think, as my colleagues have previously mentioned, the accessibility for the patient is a huge plus. But also for me as a clinician, it's lovely to be in a situation where I can get an insight into my other greater colleague in the multidisciplinary team, into their roles, particularly the GPs, whereas before this, the acute care, I would have seen a GP referral letter and that would have been the end of it at clinic. But now I'm picking up the phone. I've a lovely relationship kind of grown between our 200 GP practices. We're working on it around the area of Tala. And that's definitely going to enrich our healthcare going forward, and the shape of the healthcare, we're shaping out more into the community as well, which is it's just a lovely angle of healthcare. In my 30 years plus in the area of healthcare, it's a long time coming, but it's just really nice to be part of this. It's very exciting.
Okay, yeah, they're really good points in terms of setting up the clinics, care closer to the patient, that holistic approach, and absolutely our GP colleagues that I would have mentioned earlier in the webinar, that linkage that has been established, which would have been quite fragmented in the past. Thanks so much, Anne. I might ask another question now, colleagues. As the Integrated Care Programme for Chronic Disease, it's been a significant change in how we deliver services within the Irish health system. And we talked earlier about that culture change, but with all changes, there are many challenges to overcome. And I don't think any of us are naive to think this was all smooth sailing in terms of the impressive data that we have put forward and where we've come from. But what I'd like to know is some of the challenges that you've faced and how you've overcome them. And, I'm sure there's colleagues around the country that are in the midst of that similar challenge. So I might come to you, Alison. I'm not going to forget you this time, in terms of some of the challenges you would have came up with and how you've overcome that for your services.
Yeah, I don't know that we've overcome the challenges, but we're working on them.
Yeah.
Despite all the support, and there is a lot of support there for integrated care, but still some of our pathways are a bit fragmented still. And I think each hub has its own challenges, and each hub is a little bit different in how they set up their pathways.
Yeah.
But for our hub, we haven't been able to provide spirometry on site. So all of our patients have to attend the Mater for their spirometry. And for most of our patients, that's not an issue at all. But because of our catchment area in Dublin North Inner City, we do have a higher proportion of the population that are experiencing homelessness. But I think the most obvious challenge that we probably all have is the lack of an integrated digital patient record. And I know that that's also a work in progress for the HSE, but it definitely, I think it affects integrated care maybe more than acute care because each hospital have their own IT system. We're lucky in our hub that we do have access to the Mater IT system. So any of our patients that have attended the Mater, we can see the information that has already gone before. But it can be a problem because some of our patients could have attended any of the Dublin hospitals, but we can't access information from the other Dublin hospitals. So definitely that's a challenge that's ongoing. And I take on board what Anne was saying about building communication with the GPs in the area. And I think a digital healthcare record will help those relationships as well with the GPs and make the information sharing a whole lot easier. Yeah.
Yeah, and you're absolutely correct, Alison. There is a long road to go, and I think our policy, digital for care, is quite an ambitious policy within the HSE, and we see, a lot of sub works going on in terms of the community care record, the electronic healthcare record as our end goal, but also our shared care record. But, a lot of hubs and areas around the country have, bridged the gap in terms of linking in with acutes, but it absolutely is integral to how we should deliver this integrated care journey. And that starts with sharing information. Thank you, Alison. I might come to you, Sinead, in terms of that question as well, and challenges that you may have come across and how you've overcome them.
Yeah, like Alison said, plenty of challenges, and we're still in the middle of a lot of them.
Yeah.
I think in the early days, the challenge was identifying where you fit in the acute side of things, because in the hospital, and coming from an acute background, you realize, you don't really realize what's going on in the community. You don't understand the work that's been done out there. And you're trying to fit into a service that's already running in the hospital and create your own service, really, to enhance, cardiac rehab and heart failure. So I would have found that very challenging, identifying where to start, and then would have obviously created a great inpatient service that where we've identified patients and we got them followed up really early in the community. But then staffing challenges, and we had to flex and pivot and try and still obviously see patients and keep our services going. So I think digitally we did well. We had virtual GP clinics, so we kept that communication up with GPs digitally with them. And we created some virtual pathways such as AF in the home as well. So I think sometimes when you have challenges like that, you actually realize what you can do with what you have as well. And it makes you maybe think a bit more about where, different pathways that you wouldn't have ever thought about going on until the challenges came out in front of you. But yeah, definitely integrating into the acute sector was a big challenge.
Yeah, and I think I concur with you. It's when and coming from an acute background myself into this role, it makes you realise how my lack of knowledge of community structures was definitely an area I had to work on. But and you just talked about how you work around the resources you have, and nurses and midwives, we're renowned for being innovators, and and together with our colleagues and the wider MDT team, we come up with viable solutions. So thank you, Sinead, for sharing that. I might come to you, Mary, next, about challenges you might have had in the Midwest.
Yeah, so I suppose I was in the happy scenario that I was in the diabetes arena in the community before the integrated care program took off. So as regards Sinead and Alison and Nicola and Lorna, the challenges that they may have come up with, I suppose I had the opportunity to go and build on a current service and enhance that. So what we did was we looked at what the new things we needed to add to our service, and we kind of retrofitted what we already had to suit the integrated care program. I suppose we kind of adapted our models of care into that, and I suppose we had a good working relationship already with the GPs. So with the introduction of the chronic disease management program for themselves, it's further enhanced their pathways to us, knowing who should be going where, what's appropriate to send to us, what's appropriate to send to the acute sector. And then we're there in the middle to be able to signpost if they don't know. Or if there's queries. So the challenge was, I suppose, are you better off with starting a brand new service, or moulding an older service? I suppose we would have been in the GP practice providing clinics, so we had to come out of there and develop our own clinics, and like the girls have said, kind of I think was it Nicola was saying she has 6 clinics running, yeah, something similar in North Tippin,
Yes.
Limerick as well. You're bringing the care to the client. You're making sure you're being seen at the right place, the right time, and you know that if there comes a time within your scope of practice that they don't meet the criteria anymore, that they're either discharged back to the GP or they're moved onwards if they need further care in the acute service. So, I mean, I think we're doing a lot of great work out there. And as you said, Sandra, you know, we're bridging a lot of gaps. And yes, the IT, I think, is the piece that's missing there, and some of the staff. But I think we're getting there. We are getting there. You know, and I suppose the challenge is then with the patients themselves to make sure that they're engaged and they're empowered and that they know, I suppose we're trying to shift the ethos from the doctor's going to fix me to, you know, there's a whole team here who can help you and educate you and empower you.
Yeah, and with that patient, you know, education as well, empowering them to look after their condition as well in terms of that preventative piece. But I think, you know, Mary, as you said, the diabetes nurses were definitely a basis that this whole model was based on at the outset. So thank you to you and your colleagues that, you know, demonstrated that proof of concept in terms of specialist access to specialist chronic disease expertise within the community. Thank you, Mary. I might move on now to my next question. And, you know, as I was saying, there's lots of colleagues listening to us today that are working in the acute sector or may not be as familiar with the integrated care program for chronic disease. And if you could provide one piece of advice to colleagues listening to us today with regards to the integration of services between acute and community, what would that be and what would that look like? Marie, I might come to you.
So I think my biggest advice would be to be flexible. We work in an imperfect system, but if we are a glass half full kind of girl, you have an awful lot of resources. We're very lucky in Cork. We've got a beautiful building. We've now got governance and we have an IT system. So if we view integrated care as a roadmap, we've got all these roadmaps. We've got this wonderful opportunity as nurses to fill in the blanks and fill in the fine detail in terms of troubleshooting and making this a really good, robust service that treats the needs of patients. Up to this point, all our health services are obsessed with hospital delivered services. Now we have an opportunity to build something that's really, truly holistic and patient-centered. And if we get rid of all of the silos, I turn right for the diabetes service, I turn left for expert respiratory advice. We can view patients as whole beings, not just a suspected heart failure patient or a suspected atrial fibrillation. We can build something really, really holistic and something that probably pushes us to work to the top of our license. We don't have the comfort blanket of the hospital system. You know, professionally, we get to build our skills, our knowledge, and that ability to kind of pool our expertise. I'm very fortunate. I work with a great team of CNSs, and between us all, we all have a different varying level of strength that when you pull that synergy together, you know, I think the possibility is endless. And I think we haven't seen where integrated care can go yet. We have challenges, but we have loads of opportunity as well.
Great, Marie, and you're absolutely right. You're in a fabulous building there in Westfield in Cork. If anybody is in the locality, it is a real proof of concept of what we're trying to do with the integrated care hubs. And I love that, you know, it really pushes you to the top of your license in terms of advancing your role as nurses. Nicola, I might come to you next. What one piece of advice would you give to colleagues listening today how to integrate service?
So as always, Marie is so articulate and covered a lot there, and I would agree with, you know, everything that she said. I think we still need a lot of work to do with like awareness and building relationships between the community and the hospital settings. I think understanding the services that exist in both the acute and integrated care settings, what each roles are for, linking in early, it all can make such a huge impact to the patient. And I think even though we're all doing such a fantastic job, I can see now in a 50-50 role, we do need to keep building on that. We know that, when nurses know each other and trust each other and communicate, that the patient's experience is always better. And just to mention that when I was in Dublin, and Anne Fitzpatrick would know this because we were on the same team, but we used to do kind of a meeting with all of the CNSs, including diabetes, respiratory, cardiology, and ICPOP, probably every 2 months, just to kind of do information sharing, and we get a rep in. And it was just really, really helpful to getting to know each other. But now that I think about it, really we should be doing something that combines both the integrated care and the acute setting and all coming together, because we are still working separately to a point. So awareness and building relationships.
Yeah, that's great advice, Nicola. And I think, we absolutely should mention our colleagues in the Integrated Care Programme for Older Persons, who many are co-located with the chronic disease teams. And hopefully, we've a number of directors of public health nursing, directors of nursing and assistant directors of nursing and assistant directors of public health nursing listening today. So they may take that away in terms of integrating the teams, and that general meeting, shared learning every 2 months sounds like a really good idea. In the interest of time, I'm just going to ask the same question to one more person, and that's Anne. I'll come to you finally. Have you one piece of advice that you would give to colleagues in terms of the integration of services?
Yeah, I suppose it's not just us and them, we're all in it together. We heard lots of that 6 years ago. Hard to believe when COVID was around. But we are all in it together, and any challenges we come across, it's growth, it's shaping our service. We are still evolving, as everybody on here today has mentioned. And here's a thought: the hub and the hospital, what about the hubstable? So there's a joint just thinking of meetings going forward. And I think that's a really good idea from Nicola, because we did all learn from each other. I had insights into all my, respiratory colleagues, CNS colleagues, a day in the life of, and that's a really nice idea going forward that would really enrich what we're both trying to do. At the end of the day, it's the patient is the center person here. So, and it is enriching their experience.
Yeah.
So it's interesting. It's interesting times.
It is. Yeah. Hubstable, right? Like that one. You hasten that. And thank you so much. I think colleagues will conclude there our panel discussion, just unfortunately due to time limitations. Many thanks to Lorna, Nicola, Anne, Alison, Sinead, Mary and Mairead for sharing their journeys in advancing integrated nursing roles within chronic disease. Your passion and dedication has just oozed out over the past 20 plus minutes, and you ensure that seamless patient journey. The fact that patients stay closer to where they are, rather than them coming to us, we're coming to them. And I know we discussed this before the webinar, you're all very open to colleagues contacting you individually. They may have the same or shared concerns, or mightn't be as far down the road as you are. But thank you once again. I really appreciate your time today and your expertise, and for all you're doing in trying to implement the model of care. A really inspirational panel discussion there, and thanks once again to colleagues on our panel. A gentle reminder to our audience today to utilise the question function. It's just at the bottom of your screen if you have any specific questions or comments you may wish to ask us. So now I'm delighted to welcome 3 colleagues whose tripartite collaboration has assisted with advancing integrated nursing roles, each with very distinct and separate function. However, without collaboration and relationship building, integration would have been slow to progress. We'll hear presentations from Gemma Brennan. Gemma is our operational lead in Dublin Northwest. Next, we'll hear from Eileen Daly. Eileen is an Assistant Director of Nursing in Connolly Hospital. And finally, we'll hear from Claire Staunton. Claire was an Assistant Director of Public Health Nursing in Dublin Northwest up to recently, and is going to present today on her experience as an Assistant Director of Public Health Nursing, working within the Integrated Care Programme for Chronic Disease, but is now an operational lead. So Gemma, I'll hand over to you now. Thank you.
Thanks so much. Next slide, please. In terms of the integrated care for chronic disease, we obviously wanted to stand up these hubs quite rapidly in the community to make sure that we could support CDM in the chronic disease management program in general practice, and patients could have rapid optimization of their conditions as well as self-management support. So it wasn't simply offering an outpatient unit outside of the hospital. We needed to deliver care differently. This wasn't necessarily straightforward from a nursing perspective. A lot of the nursing team had come from only working in a hospital setting. So it was a new way of delivery, and I just wanted, from a lived experience perspective, to share some of our learnings from that. Next slide, please. So the team that we had, we rapidly established because part of that was that we actually had demonstrator posts in the community for a number of years. So for nearly a decade, we had, like Eileen had staff in the hospital that were carrying out outpatient department clinics, and we had community nurses that were based in GP practices as demonstrator posts. So they were historically counted as part of the staffing in the hospital and in the community, but actually the new model was kind of bringing in the future of what we wanted to do with those posts. And it didn't at the start really fully match. So standing up of the hub was really rapid. It was a big change, and we needed to make sure that all the stakeholders were engaged as part of that change journey. And the staff that had been in demonstrator posts, a lot of them had applied for the new roles. So we actually don't have any demonstrator posts because everybody had moved into the new ICPCD roles themselves. But then we had to review the current practices of those demonstrator posts and say what was the best use of the resource. At this point in time, because everything was happening so quickly and everybody was new, and we didn't necessarily have that psychological safety and trust in one another as leaders, we had limited consultation with the nurse management team at an exec level at the start, which was a challenge. And there was a view that whilst the community was enriched, the hospital was left a bit short in terms of staffing. And so this was challenging for both existing service delivery and morale. Next slide, please. So what were the building blocks? So really, to rapidly stand up this successfully, we really needed to have really clear governance structure that supported both the hospital and the community leadership. We had a dedicated person in the hospital from the start who was the health and social care professional lead. So like she was my go-to person. But that was a challenge because then when she moved on, it was like there was a bit of a change there, and we needed these governance structures to be more robust and not reliant on individuals, if you like. So what we set up was quarterly workstream meetings for each of the specialties, where we invited both hospital and community management as well as the team themselves to participate. And we also engaged with the GP leads in each of the network areas early on, so they're represented on each of the work streams. In our area, we're very fortunate to have a practice nurse coordinator, so they were really instrumental from a nursing development perspective, developing the CDM from a practice nurse perspective, and their understanding in practice nursing and in public health nursing about what the role of ICPCD is now with the new model of care. And we actually maintained a level of delivery for the outreach in the community, because we have in our area a huge amount of hard to reach groups, and we wanted to make sure that we would be using that experienced CNS resource predominantly to meet the needs of those people that might find it challenging to access the hub directly. I'm just going to hand over there to Eileen, she can take you through the next steps.
Next slide, please. So, as Gemma said, I'm Eileen Daly. I'm the Connolly Hospital ADON, and I'm just going to give my perspective from development of the integrated care programs from the acute hospital perspective. And I suppose we had a lot of challenges over the last few years. But I suppose one of the biggest things from my perspective is that there was definitely at the start a lack of information and consultation at my level, at ADON level, to outline the IPC chronic disease service, the vision and the implementation plan. And although there may have been introductions for the specialist teams and the nursing staff, at the start of the process, we felt that our involvement was not as it should have been. I think if we had been involved a little bit earlier, we might have been able to support the process and the transition a little bit better. But as I said, we have sort of resolved those issues over time and built up our relationships. And that's very important. One of the most important things is to develop the relationships with the staff in the hub and with the managers, the operational leads, and the PHN add-ons as well, so that we can sort of have a vision together going forward. As Gemma mentioned, we had historic demonstrator posts, and they were very much part of my team in Connolly with outpatients covering leave and integrate into our team. And I said that's sort of how myself and Claire sort of ended up meeting together, because my understanding of what they should have been doing and Claire's new vision of what they should have been doing was different. And by meeting her and working through what the expectations were, we sort of, I got a much better understanding of the evolving changes in the integrated care roles and the vision for those roles. Now, what it did left, as Gemma has alluded to, left me with gaps in my service, because I said they had become integrated into my workforce. But that was obviously something over time I had to work on separately. And obviously Claire then made sure that I was linked in with the workstream meetings. So again, that gave me a much better understanding of the whole integrated program, the progression in the hub, how the pathways worked, how the GP, the liaison part of it worked. And you know, that was extremely beneficial for me in trying to implement the service from an acute hospital perspective. Okay, there was a lot of challenges, and there are still ongoing challenges. One of the ones that we had, we're very lucky in the acute hospital that we have not only consultants available, NCHCs available to support our AMPs and CNSs nearly all the time they're on site. And I said, because we have a primary consultant in the community, they really do have to have robust systems in place to ensure the CNS and AMP are well supported. And you know, that's something they have to do themselves. And that's one challenge that is mentioned to us. The roles also are all evolving from the acute CNS role and the AMP roles. In diabetes and respiratory, it's quite specific. They have the complex type 2 patients for diabetes and your COPD and asthma patients for your respiratory. But cardiology, there's a wide range of specialities to be addressed, including heart failure, cardiovascular disease, structural clinics. And what was happened in the early days, some of the nursing staff may have started down one road of speciality like arrhythmia clinics, and then because of demand and also the level of referrals, this sort of changed into a more general approach. And I suppose this new document that's been launched, the operationalisation of the roles, will give us great sort of guidance on what they should be doing and how we should be developing them towards specialist roles and specialist knowledge. And I think that's very important to keep in mind. The other challenge obviously is clerical work, and so that's an issue across all services. We know that we don't have enough clerical support behind some of these roles, and you know, ideally you want them spending their time in clinical settings, but unfortunately the clerical end of it has to be addressed as well. But there's been a lot of positive outcomes. We've developed a good team working between the nursing staff, the MDT, and between the hub and the hospital itself. We support each other with practice development and educational support. I think Claire will go into a little bit more detail about that. We've had nurse-led initiatives taken off, such as the Gateway Clinic, which was in diabetes, where the integrated nurses looked at what patients were suitable to move into the community for follow-up. And we had sort of things like the arrhythmia clinics developed in cardiology. We also have sort of the bidirectional pathways of care. So basically that if we have people who their diseases are progressing, we can move them back into the acute sector and vice versa. So we have those pathways there to support each other. And obviously the most important thing is that we're providing a quality care for our patients in the right setting, the right time, as is everybody's aim. Just next slide. So again, making it work. From my perspective, the key things, and I think Claire and Gemma will agree, that it's been fully informed of the vision and the implementation plan, developing those links between the hub and the acute hospital sector and building our relationships. The workstream meetings are very important, and Gemma and myself has had a discussion that we feel there should also be a more structured link maybe between the operational leads in the hospital and in the community, so that we can make sure that how we're implementing the integrated care programme is consistent within both services, and they could maybe hold local meetings around that. Obviously, structured and clear reporting structures for our CNSs and AMPs, and as an embracing change. I'll pass over now to Claire, who'll give her perspective from the community side. Thank you.
Thanks, Eileen. So my name is Claire Staunton, and I worked as the Assistant Director of Public Health Nursing, so I'm speaking to that side of things. And I'm going to speak to the enablers for relationship building and service development. And the first big enabler from my perspective as an ADPHN with this very new model was the environment. So as Gemma mentioned earlier on, the hub was in place and the physical space from the latter quarter of 2022. I, as the ADPHN, I was new to the role, and this was a new model of care. We had most of our staff recruited by the middle part of 2023. So I made myself available to be on site 2 out of the 5 days per week. And that was huge, really, and very valuable in relation to, I suppose, meeting the whole team, the integrated care team generally, so the consultants, the MDT generally, forging relationships with the ops lead. We were both new in the role, and there was that support development. So that co-location made a huge difference to that relationship building piece for me in the role with this new model. And the next big factor I'm going to draw your attention to is the fact that I was assigned the ICPCD team specifically. And by that I mean for a particular period of time, so for just under a year, my Director of Public Health Nursing, Kathy Garrity in Dublin Northwest, assigned me from a line management point of view just to this particular team. I obviously had other remits within my EDPHN role, but from a line management and developmental point of view, I could give some dedicated, protected time to developing and implementing this model. And that was, again, very valuable. And that enabled me to build relations, both within integrated care in the hub, but also to forge those relations with the staff in the hospital. Next slide, please. This slide very much focuses on a change management piece, and I'm going to give the example of the Gateway Clinic Eileen alluded to her earlier on in her slide presentation. So this was very much, like I say, a change management piece, and it was the community diabetes nursing team that came to me with this. They communicated to me earlier on that when they were going into their hospital, into the diabetic day centre for their 1 day a week, that they felt their role was very generic and really wasn't aligned with the model of care. And they felt there was an opportunity to build a clinic that would very much pick up the clients that we, within our model of care, are looking to look after. So the referral criteria was very much aligned with the model of care. It was catchment specific to as well. And that clinic would work alongside the Diabetic Day Centre, and the positive impact would be patients would be seen sooner, both within our particular model, but also have a positive impact on patients coming into the Diabetic Day Centre generally. So in order to explore the feasibility of this particular nurse-led clinic, my first step was to link in with Eileen in the hospital, and that's what I did. I reached out, I sought a meeting, and we met. And from that meeting, Eileen spoke to it earlier on too as well. We had a discussion around this new model. There was an opportunity for me to educate Eileen on this new model, and also for me to learn about the existing ways of working too as well. So from that meeting, I then invited Eileen and her colleague out to the hub, and at that point then the nursing team did a presentation on the Gateway Clinic to Eileen and her APHN colleague at the time. And really from that stage onwards, both Eileen and myself led out, Eileen very much focusing on the hospital side of things. She would have communicated with the Director of Nursing in the hospital, would have facilitated the business manager meetings too as well in order to facilitate this clinic. I led out from a community point of view, leading the staff in that way. So this clinic that it was very much driven by the community nursing team. It was aligned to the current model of care, but the input was very much dual. It was a co-designed feature both of community and of hospital, and that was a very positive effect on the clinic. The clinic is still running today. Next slide, please. I'm going to speak now to the benefits of collaborative working. So Eileen mentioned earlier on too as well. I had a CNS, a candidate ANP rather, who required a period of clinical exposure to enhance her year of candidacy, and there was a gap there. So I reached out to Eileen. Eileen and the team within CCU in Connolly were extremely supportive and facilitating in securing this for this candidate ANP. That was hugely beneficial for the candidate ANP herself, but also for the whole team. And it really fostered a good relationship between the community staff and the hospital staff in a very integrated manner. And then laterally then, I was able to return the favour. Eileen reached out to me. The Diabetic Day Centre in Connolly at the time were really struggling and going through a challenging time from a nursing resource point of view. And for a short time, the community nursing staff were able to facilitate clinics, and that permitted a continuity of care in the Diabetic Day Centre and fostered integrated team working, benefiting both services. Next slide, please. And just to conclude there, you can see by the big circle in the middle, from my perspective, and I think from all of our perspective, the relationship building was key. So in summary, relationship building is the foundation to shared leadership, collaborative working, and to co-design and facilitating better services in integrated care. Thank you for listening.
Wow, many thanks, Claire, Eileen and Gemma, for sharing your experience. And it's really refreshing to hear, you know, the obstacles that you've came across and how you overcome them. And it was a fantastic presentation on the lived experience of that relationship building and collaboration by key leaders and managers within the services. I was particularly struck by the importance of communication, and specifically with the Assistant Director of Nursing and Assistant Director of Public Health Nursing, and how that is vital both for the professional responsibility of nurses working within integrated care, but also for the continuity of the nurses who work across both community hub and in the acute hospital. So thank you. Okay, so we might move on now to questions and answers. I know we're running short of time, so we might just pick some of the most common questions that have come in. Niamh, if you'd like to bring some forward.
Thanks, Sandra. There's one question here. I am part of a respiratory integrated team. There's a number of posts that were not delivered prior to the pay and number strategy. Is it possible for us to deliver a full service and develop pathways, and will these posts be restored?
Okay, and I'd imagine that's affecting a number of services, not just respiratory. And while we recognise the significant impact the pause in recruitment and prior to that, the pay number strategy is having on the ability of teams to deliver a full services, I suppose under the new integrated health area and regional governance arrangements now, responsibility for recruitment and replacement and progression of posts have been devolved to regional levels. So it would be our expectation that regions will utilise this devolved authority and support the phased development of sustainable and integrated teams where population needs service outcomes clearly justify this. And I think we've got really good data in terms of where we have full teams in place and their ability to reduce waiting lists, etc., is just been phenomenal. So we would encourage everybody to discuss locally, utilising their own business case and data that they may have in terms of ensuring that teams are aligned to the models of care. Is there time for one more, Niamh?
Maybe one more short question, Sandra.
Okay.
Another one here. I'm currently not a nurse prescriber and working in a cardiology integrated care team. Do I have to complete nurse prescribing?
Okay, and I just noticed my colleague from the ONMSD, Annette Cuddy, is on, who leads out on the nurse prescribing medicinal products within the ONMSD. So in essence, yes, nurse prescribing is a requirement of the role and it's reflected within the national job descriptions for nurses working in integrated care, cardiology teams and all teams for that matter. And, you know, the ability to prescribe is considered as a key enabler in delivering timely and effective patient-centred integrated care and supports nurses to work to their full scope of practice. And what we would advise is that colleagues would link in with local nurse clinical leadership to support the progression in a structured and supportive way. And if required, link in with the ONMSD who continuously to strongly support nurse prescribing. And again, unfortunately, because the website isn't currently operating, but there's a lot of information under the ONMSD website in terms of nurse prescribing. Niamh, I think we'll leave it there, and what I'll do is we'll put together a list of frequently asked questions for colleagues and we'll circulate that with the recording. I might now ask Dr. Sarah O'Brien to join us to present, to say a few concluding remarks. Sarah, over to you.
Thanks, Sandra. I'm conscious of everybody's time, so just a couple of thoughts before we close. I think the recurrent theme throughout this webinar has been that of collaboration and really working to develop relationships with colleagues across acute community and general practice to drive that unified, integrated end-to-end approach to patient care. I suppose my hope is that the regional structures will strengthen those existing relationships and work to establish the new ones in order to enable delivery of local care that flexes to meet the health needs of the local populations that you serve. Another key message that struck me from today's webinar is that the integration model of care for the prevention and management of chronic disease is making a real difference. I mean, yes, we know that the levels of activity are exceeding national targets. We are seeing real impact in terms of reductions in emergency admissions to hospitals, in terms of reduction in waiting times for scheduled care, particularly in sites where acute and community teams are working together to implement the model, such as what you heard today. And obviously, you know, most importantly, the patient reported experiences of services in the community have been overwhelmingly positive. But what today has really brought to the fore, and what's really powerful, is to hear the nursing voice from colleagues today. Yes, there are challenges. Yes, this does represent a significant change in ways of working, and we are early on in the journey, but this model is already delivering positive change for patients and staff in the care that's being delivered, and that's just extraordinary and really positive, and something we need to continue to build on despite all the change that's happening all around us. I think so. Within that context, supporting and strengthening these nursing roles and enabling community specialist team colleagues to work in those new ways is absolutely critical in terms of meeting our National Service Plan objectives for 2026. And these documents that are being launched today will support in that endeavour. Obviously, we want to share the learning. So if any of you have examples of innovative patient pathways or new ways of delivering services, please do get in contact so that we can highlight and share your experience. And I just finally want to thank all those who have contributed to these documents and to the webinar today, and to all of you who are currently working in integrated care for your hard work, care and persistence in delivering on the models of care. We're seeing it is making a big difference to the patient experience and health of our population. Sandra, I'll hand back to you to close. Thanks.
Thank you so much, Sarah, and thank you for your guidance and leadership in progressing with the model of care. Colleagues, just all that's for me to say is to thank everybody for joining today. We've had huge numbers joining us, and I really want to say a special thanks to all our panelists today who have given up their time to share their experiences. And I hope you have found it beneficial. I'd like to also just a special mention to Niamh, Siobhan, John, and Sarah for their help and assistance, and all the ICPCD team who've helped make this webinar a success today. So thank you, colleagues, and we will talk to you soon. Take care. Bye-bye for now.